lungs?
I don't know.
They like to breathe, so that's probably, no one loves the lung, but I think that we respect that, right? So I guess, like heart, we talk about the anatomy of what's important on there, right? So obviously the sternum is the centerpiece of the rib cage there, right? The top part's called the manubrium, right? And the body, and then the little tip is the xiphoid process. When the ribs come off. And we know how to determine where the second rib is, correct?
Yeah.
How do we determine that again?
You look for your clavicle.
Suprasternal notch, and then you go down.
Five.
So what are we feeling for?
The angle of the
Sternum joint, where they junction together, right? And they fuse in like an ugly lump.
Yeah.
Then you go across, and that's what rib?
second.
And then which is the second intercostal space?
Just below it. Just below that second rib.
Is it below or above?
Below.
Below. Below. I don't know, I just know how to put the second.
Right? So it's below.
Below the second rib.
So it's tricky to get those first ones, right? So first is right above it, and the first rib is, that's a trickier one to find. So, okay? So the sternal angle, so this is just locating it, right? So we know where the second rib is, right? And the second rib comes into level of T4, so you have an idea of where that comes in. Okay, so we have that sternal angle, blah, blah, blah. So only how many ribs articulate with the sternum? 7. You see there's 3 down there that sort of fuse together, and then there's how many that hang off?
11.
That float on the sides. You can feel they're kind of floaters.
Yeah, I wish.
Can't feel them? I can feel them kind of like they're bending a little bit. You push them.
Yo sé.
Where I got too much.
Well, you have to go down to the bottom of the rib cage. It would be the best way, right? Like I said, this is, it's okay to touch yourself in this class, right? You come down here, right? That's gonna, thank God. I've been waiting for a class
get
where I
over
can do this. Right, and then that's the 10th, right? You come to 10th, and then 2 hanging below it, right? You go more side, you can push them. Did you feel them and move them? Do it just for the experience, not like as a, not too much. Just say I did it.
Feel the end.
I lived it, I did it, I got 12, he moved. If you push him, anybody feeling 12? There's 11.
Yeah.
Come on, seriously, who's really doing this? It's only me and you doing this stuff,
Alright, done.
alright? Well,
When we're thicker, it's a little harder.
well, okay, just go along with it anyway, right? Okay, this is just a little idea on there, right? So we know that, 2 comes in at T4, so, right, the base of the scapula is the 7th rib. Those are just general landmarks. It's kind of hard to feel your own scapula, but I guess you can, because you move them when you do this too, right? And the most protruding is, when you flex your neck, is which vertebrae? C7. So everybody feel it?
Mm-hmm.
Been there, done that, chalk it off the list? So 7 is the end of the cervical vertebrae, right? And the next one below it is T1, right? And how many T's are there?
12.
12, and they correspond with all of the right? Same number of ribs, right? And then what's below the T's?
It's lumbar.
Of the L's. How many are those?
5.
5, and how many S's?
I always forget the 6.
Sacral, 5? Right, they're kind of fused, right?
Yeah.
And what's the last thing? The C's?
Back to more C's.
More C's, Rebecca again, right? And then we start again. So yeah, so for anatomical landmarks, of course, kind of knowing how to define it, something mid-sternum, right? We're talking mid-axillary, mid-axillary line, right down the underarm, down, so the anterior would be, we're kind of at the border, and posterior would be at the other border. So they're just definitions on where we're kind of listening as well. So you got it, right? Vertebral line, of course, and mid-scapular lines. kind of have landmarks on where to look at for different lobes, and this does not really clearly show on this. I think what actually does is so remember, just mostly from the front, it's, you can access 3 lobes. You kind of laterally, but in the back, you really can mostly only access 2 lobes to listen to them. So we were doing that. And they move down when you breathe in. So you can see on the right side, if you want to access the right lower lobe, you have to almost be listening on the side. And if you want to access, so you can't really access the middle lobe, right? So I'm just going to show you a video. I believe this is the one that probably shows the best on that site. The Fuss did a good job of showing you where. They got a good rule for kind of figuring out where the lobes are, and I believe this is it. We got speakers on? We get live? I don't hear music yet.
He likes hot stuff.
Always wash your hands. Just a disclaimer.
In this session, we're going to focus on percussion. Percussion is a technique discovered fairly recently by Leopold Owenbrugger. The story is that he was an innkeeper's son and he watched his father tapping on casks of wine to see how much wine was left. And from that, when he became a physician in the late 1700s, he discovered percussion. And everything we know about percussion.
There wasn't a lot of qualifications you needed in the 1700s to be a physician, apparently, right? You just had to have an interest in tapping on wine and stuff like that. So.
He described. He used an instrument that they laid on the chest and a tiny hammer. In fact, the present-day knee hammer has its genesis from that instrument. But we've found that we percuss much better when our finger is the pleximeter and our other hand is the hammer. I know that there are many different ways to do this. I favor you're putting your hand firmly against the patient's chest, not keeping the other fingers up, because I think it's harder to form a good seal. So push the fingers in, seated nicely in the intercostal spaces, and you're trying to aim for the middle of this phalanx, and it's important to keep your fingernails short in order to percuss successfully. Your wrist must be loose, and if you get all these things going, you will have a nice percussion stroke that will serve you very well. You're detecting a slight difference between left and right. And that is quite normal. That is the area of superficial cardiac dullness. And now we're going to go over the surface anatomy of the right side of the lung. Because if you think about it, there's no point in percussing and encountering an abnormality, dullness, say, if you don't know the normal anatomical boundaries and don't know if that's liver or lung. So I'm going to point out some of the surface markings and I'm going to draw them for you. If you were to put your finger in the suprasternal notch and bring your hand down, you would encounter the angle of Louis. It's a very important landmark. This is the suprasternal notch. Because lots of exciting things happen there. It's the level of the right atrium, the trachea bifurcates, the thoracic duct crosses over, the advocus vein joins. That's the lower border of T4. And for us, it's very helpful because the second rib joins right there, and therefore the space right below it is the second intercostal space. Now, in percussing on the right side, we must be conscious of the location of the major fissure, because the major fissure will divide things into the upper and lower lobes and the minor fissure. And I'm going to show you an easy way to do that without having to remember too many landmarks and so on. So let me demonstrate by having Jeff turn around for me a second. Now, this is the medial edge of Jeff's scapula with his arm at his side. So if you remember this is where his scapula is. I'm now going to have him put his hand on top of his head. And the really exciting thing happens is the moment he puts his hand on his head, the lower border of the scapula becomes a wonderful landmark for the major fissure. So this is the lower border of the scapula. And if I continue it up, and then continue it through the side like so. It will eventually come meet the costal margin at about the sixth rib, right about there. And the median fissure, or the horizontal fissure, is found by drawing a line from the fourth rib. And if you follow that line, it eventually intersects with the other line. And as you can see, the axilla is the only place where you can see all three lobes of the lung: upper lobe, middle lobe, lower lobe. When you're examining the patient from the back, you're largely dealing with lower lobe with a little smidgen of upper lobe. And when you examine the patient from the front, you're mostly seeing upper lobe with a little silver of the middle lobe and a tiny silver of the lower lobe. In percussing the right side, it's terribly important again to know where the liver is, and especially to know the upper border of liver dullness, because the liver is here, it is dull when you percuss over it. You need to know the upper border so that you can say any dullness above that is fluid or consolidation. And the magic numbers to remember are 5, 7, 9. 5, 7, 9. The fifth rib in the mid-clavicular line. So here's the second rib, third, fourth, fifth. Right about there's the fifth rib in the mid-clavicular line. The seventh rib in the mid-axillary line. I'm going to turn Jeff a little bit and have you put your hand on your head. And I'm going to find my landmark again.
Oh, yes.
Here's the seventh rib in the mid-axillary line. And the ninth rib, if I can turn you all the way, put your hand down. The ninth rib in the mid-scapular line, the ninth rib, which is about there. So remember the magic numbers 5, 7, 9, representing the mid-clavicular line, the mid-axillary line, the mid-scapular line. If you have dullness below that, that's normal, that's liver. If you have dullness above that, especially if it's considerably above that, it's quite abnormal. In percussing the left side of the chest, it's really quite different from the right side. On the right side, you have the solid organ of the liver to contrast its dullness with the resonance of the lung. On the left side, there's a slightly different situation. So on the left side, you have the heart. And as I mentioned before, you have a fist-sized area of dullness, which we call the area of superficial cardiac dullness. Everybody should be dull there. And if they're not, it suggests hyperinflated lung. The pulmonary second space, again, should always be resonant, and if it's not, it suggests perhaps an enlarged pulmonary artery. But the very interesting phenomenon here has to do with the gastric bubble that sits under the rib cage. Here is the lower margin of the rib cage, and the gastric bubble sits underneath there in an area called Traube space, which I'm going to outline. Traube space, spelled T-R-A-U-B-E, is formed by dropping a perpendicular on the sixth rib in the mid-clavicular line. So here's the mid-clavicular line. Here's the second rib, third, fourth, fifth, sixth. So perpendicular from the sixth rib in the mid-clavicular line, and another perpendicular from the ninth rib in the anterior axillary line. And what you then get is an irregular quadrilateral representing the stomach bubble sitting quite high up. Don't forget, the diaphragm is quite a dome, even though the costal margin is here. And when we percuss the lung and go down this way, we go from resonance typically to tympany from that large solitary bubble. So listen to this. You hear how it became a much fuller, boxy sound, unlike this sound. And that represents the stomach bubble. It's a useful sign because if you have a pleural effusion on the left lung, it will seep into the costophrenic angle and it will obliterate the Traube space. Whereas if you have a consolidation of the lung will be consolidated, the lung sound will be flat, dull, and when you come here, Traube space will be preserved because the lung boundary is over there. This represents the costophrenic recess. And so it's a useful sign in that situation.
Hands after. That's a pretty cool way to really be able to identify those landmarks on it. So looking back here, right, so, do you remember when he said how to find that middle lobe? What the right side, right, that's the only, right side has a middle lobe, left side only has two lobes, right, an upper and a lower. Right, you come down the clavicle, right, bring it up to the fourth, right? When you come to the sixth, and then draw a line to the fourth where they intersect at the midpoint. So you see this drawing kind of has the right middle lobe more accessible in the picture. But it really is only accessible in a little piece and on the side. So can you listen to your middle lobe in the back?
No.
No.
It's just unnecessary.
So you got to make sure you're listening in that between the 4 to 6 lines that intersect at the mid-axillary line. Otherwise, you're missing that lobe on there. So, do you understand that about the liver on that one? So that was
Yes.
pretty cool too, right? That's probably like a real life way to do it, right? And shortcut things. So. Lost track of this. So I think we're familiar with some of this. You know, supra means above, infra, inter means between. Okay. In this case, where the bases of the lungs are at the top or the bottom? The base of the heart is at the top or the bottom?
Top.
Yeah. So they're kind of reversed, right? The apex of the lungs is at the top and got it. You got it. Okay, so and a topical. So we know we're going back to T4, right? Where we're thinking about this, which is at the what rib? Second rib, right? So this is the level of where the trachea bifurcates. So we're realizing this makes a difference when we're listening for bronchial sounds, bronchiovesicular sounds, or vesicular sounds. So we know where we're kind of listening at that, right? So he said it was an exciting area, right? So I guess that's exciting if you're really into that, but it's kind of good to know that you don't have to memorize something different. So we talked about this, right? So your lung, of course, is covered by a pleural covering, right? And it has a space in there, and of course, a pleural effusion, right, can cause filling of these spaces as well too. And you have a visceral one, which is closer to the lungs, and parietal one that's more distant. So this is kind of stuff we already know, right? Where the sternocleidomastoid, we know about breathing, and these are the muscles that may be important: the scalenes, the sternomastoids, right? We can recognize those, the sternum attached with the clavicle and the mastoid bone, right? Where's the mastoid bone? So we know it's that big muscle group that comes up here, right? It comes back to the mastoid process, and it comes down here, attaches to the clavicle and the sternum back there. You can feel your mastoid bone. You could just follow the big muscle up, right? Just grabbing that muscle, all up. Nobody likes feeling that thing. You can't do that to your patients. They won't like if you grab that muscle like that. Then it comes up to the mastoid there. But if you don't know where it is, grab it. If you really get lost on that, right? Because we're also going to use this later for doing lymph nodes, too, right? We use this as a term whether we're looking for anterior nodes or posterior nodes. So you got to know where it is, right? So, got it? Everybody's feeling this muscle? No doubts about it. This is your chance to have no doubts about where it is. You know, and just feel it. Hold on to it. It comes into the mastoid bone up here. You can feel where it is back there, right? So, and it branches down to the sternal head and the clavicular head, and hence the name of it. So we know we talked to death about the health history, how important it is. We know when we're presenting with different things, whether they could be cardiac in nature or pulmonary in nature, they can be very similar. And these are some examples, some initial questions that go on. I don't think we need to really go into too much of that, right? So we might, in the review of systems, ask, depending, if they have some of these specific complaints, especially if their chief complaint is a pulmonary related one, or it's within the differential, your initial consideration of that. Right, asking what the characteristics of cough is, dry or sputum, what color is it, what's coming up, any consistency, volume, how much is really coming up, is there blood in that as well, of course. You're all taking health promotion as well?
Yeah.
So I guess you talk about tobacco cessation, right? So I think probably, the third one, assessing patient's readiness to quit, is probably one of the most important things really there. Did I talk about this before, right? Assessing readiness to change. The stages of change model, right? Remember, ever heard of that? Who did hear that? Come on, this is not the first time we must have. Heard of it, something's ringing in there, right? Let's see what. So this is kind of, this is why we use some theories to kind of go through this. This can kind of help people when it comes to change. It's kind of a good way. Here's a, So right, there's these phases called like pre-contemplation. We'll look at the one over there. I don't know if I can get that big one or not. But you guys think you can kind of see it, right? Pre-contemplate, looking at this guy. This is a stage where people are thinking about changing. There's it's even before they're thinking about changing. Contemplation, where it's kind of on their mind. Where their preparation is where they're preparing to change. Action is when they're actually doing actual things, and then maintenance, and it may or may not relapse could happen. And then you may have to go back and start the cycle again, but you could stay in maintenance for a while. So when we assess readiness to change, in a level we kind of assess where they are, in what stage they are, because what are most interventions for patients? What do we tell patients who are smokers? Which is, when it relates to the stages of change, what stage are we at when we do that? Action. We're giving them actionable items. But where are most people on these health issues? Pre-contemplation or contemplation. So if our intervention doesn't match the stage, we get poor results on this. So maybe we need to add some education, or maybe we need to even address it to see if we can bring it to contemplation. Or maybe we can ask them, if you were to quit, what would you need to be able to be prepared to quit? Like, what would you need set up? Because if anybody who's tried to quit, they have withdrawal symptoms, and if they don't have some level of preparation, maybe they're concerned they're going to overeat, or they're going to be cranky at work, or something like this, and they want to have some plan to be able to be successful in that. So assessing readiness, so we know about that. Motion here. Okay. So we know this. We can use the same type of things, right? Inspect, palpate, percuss, auscultate. So ideally, inspection of a patient, right, should occur with an open chest, right, like you did in the video, not someone just with clothes on, because you don't know how many layers these people have on, So you really want to be able to see the front and the back for symmetry, what you really observe about it. That's kind of obvious stuff, but how many times do we really, how many, okay, so be honest, when you've been to you want to get the most out of your insurance, so you go for your annual wellness exam. I have my questions whether I should go for that or not either. I kind of feel like it's a waste of time,
Really?
But do they inspect it?
No.
I mean, I have my clothes on the time, and they do that little junky.
Yeah.
I look like it's like.
It's like that. I just think I
know.
just want them to cover the labs. I think that's all I go for, and I gotta listen to these people like.
And we are healthier than the average. I mean, like, I
Well,
would
they're-
hope that if they're really sick people, they would be doing it well.
I don't think that.
I would hope. I said I would hope.
I would hope that. I would hope that. I mean, that would be nice to think. But you can do it very quickly in people, right? I mean, who are healthy, they're easier, right? They're easier, just look, we did a quick thing, you know? I had,
You know what
even
we do
when I
with
went to
kids?
different, I pick them different every year, I'm a PPO, so I
You
just kinda pick.
inspect.
Isn't that
Yo no le
sad?
hablo.
Sí,
And
claro.
Very
pa-
attractive.
My
pero todo
sister had
eso
passed
es-
away from a melanoma.
los
So I
niños.
have a risk of that, right? But I'm not, probably not so much of a sun person as she may have been, but. So she goes, oh, you should have that checked out. I was like, well, why don't you just go over here, just look? Like, there's like areas I don't check. Like, just look. Just show me an extra eye. Like, I can see what's in the mirror and stuff like that, and anything suspicious, but didn't even like, I was like, nah, forget this nonsense.
Awful.
Don't tell me to go, just look. If you would've had me, right, in a gown, you could've looked and you could've said, from what I see, I'm not a dermatologist, I don't see anything suspicious. You could've just been done with it, that's enough. I mean, I said that was enough anyways. So inspection, we should ideally do this. We know that we can find more. We know pectus excavatum from the quiz, right? You know, we can have chests that protrude or chests that are concave. We can have more barrel chests. The structure can change over time. We can have conditions with the spine where there's more lateral curves like scoliosis or kyphosis where people coming over there. We see that kind of everybody getting that hunchback thing going on. You know. We talked about that, right? We talked about the pigeon chest, right? So
La inspect.
the guy on the bottom also has the other buttons, so I see this apparently, right? So that's what it'll kind of look like, not very clear x-rays on how that would look, right? But you can see how it is in there. So he's a barrel chest, I guess, you know, I mean, he's just kind of also a little chubby around the you know, abdominal adiposity as well too, but that's how the x-ray would look a little more fuller. You don't see a normal one here. So you see in the scoliosis, we kind of have a lateral curve. Remember, scoliosis is the lateral curve, and kyphosis is the right. So it's a curve forward. So we might see use of accessory muscles, but we know all this from nursing as well too, or scars as well. So we all know look with clubbing, right? So
Yeah.
put them together like that, and you see everybody has done this before. Let's see if there's clubbing.
Yeah.
You should see a little what?
Diamond.
Maybe like a diamond-ish.
Yeah.
Ish. Anybody's not done this before? Been there, done it, lived
I've
it?
never done it.
Do it. Live it. You ever seen that? Do you see a little diamond?
Yeah. Tienes
The
cloven, tienes
upper joint in
cloven.
there.
Ah,
You
que
gotta
te
kind
veo.
of see a diamond, right? It could be an elongated diamond. You don't want to get your,
Te
you
veo
don't want
mirando
to get your
mucho.
clubbing or
No, pero
something
aunque
on
no se
this.
parece diamond is normal, right?
Could be, right?
Te voy a meter
So this
la
test
cara.
would affect all that, right? But this is just
Es
general
normal.
things, right? Causes, we know these
Yo
causes
me
of
estoy acordando
these.
de la cara
A
cuando
lot
tú
of
entraste
causes
ahorita,
of
parecía una...
clubbing and cyanosis. We might see
Si tuviese-
staining,
eres
we
una
may
loca.
see redness in
Una
the
cara
palms,
trampa.
suggesting maybe some vascular issues or oxygenation. So palpation, same way that we palpate others, right? And we can go through those. So we know how to test for chest expansions,
Tar stain.
right? Usually, very hard to do it on myself, right?
Yeah.
You know, on their thumbs together,
Oh, yeah.
watch it come out, like that.
Oh, yeah.
So, watch them breathe in, it can be done at the front, right? You can see it on the back, changes at the border of the ribs. How about tactile fremitus? That's a palpation as well too. How's that test work?
Patient says 99.
And what do?
You
You feel. There's resonance.
What's considered normal?
I just remember.
Which is more feel, what you're feeling is. Well, try yourself, 99. What do you feel? 99?
99.
99?
I don't feel anything.
99?
99.
99.
Right? What do you feel?
Like
Vibration.
vibration.
So really, the only value of the test is it's very hard to measure like more vibration, less vibration. It's really to see if there's any asymmetrical
99.
differences.
Sí, 99.
That will be the only concerning part of that, if there's asymmetry.
Sí.
Meaning no vibration on one side.
Right, or it's drastically different at the same places on there. So then again, this is comparing symmetry on here.
Yes, sí. 99, 250.
Okay, so these are causes of asymmetric lung expansion. Really, most of these tests of palpation are just symmetry. Make sure they're moving in the same amounts. If one's moving and the other's not, you're going to think something else is going on. But this isn't going to be like isolated features you find. These are going to be people come in with complaints. If anybody on this list is going to have a complaint, you know, you're not going to give them a surprise diagnosis, right? That they didn't already know. They're going to have something chronic, something shortness of breath, some sort of pain, and then you're going to use it to kind of support it. So we talked about tactile fremesis, right? These are positions you would do, and these are going to be on your exam as well too, when you do your assessment.
So this is just,
This is how to do these. These are going to be your skills. This is your skills stuff. I mean, there's not much more to lung anatomy. We kind of did that already.
right, but I'm saying like the,
You may have to know for like the exam what tactile fremesis is checking or what might be concerning about it, those type of things. You're not going to demonstrate it on the exam.
no, I understand, but I'm
Right,
saying
you're not
like
gonna see
all
this.
those spots is where you're gonna be checking the 99.
Like 1, 2, 3,
Gotcha.
in there, right, kind of there. So,
So if there's more vibration, you worry about.
only asymmetry, asymmetry in some way. They can have low vibration throughout, that could be normal, high vibration throughout, you're feeling a lot, you know, very subjective. You're worried that there's vibration on one and not vibration on the other, or a drastic difference. But the test is not good enough, like I said, it's not good enough to determine
Exactly.
any issues on their own outside of a complaint.
Yeah.
Like I say, the test is not useful as a routine test without a complaint. That's why we don't do tactile fremesis standardly.
Right, it's more routine like oscillatory.
Right. Because we might detect the problem there
Percussion,
as
But
well.
percussion.
The previous slide said if in the presence of consolidation, fremesis is more pronounced,
Right,
and then it's decreased in a perfusion.
right, but,
Of course, the patient will have a.
right,
complaint,
again, it's gonna be a
but-
consolidation on one side,
Okay.
like maybe a pleural fusion on the other, right? So that's what's usually you're looking for asymmetry, but you can't really tell, because people's lung structures are naturally gonna be slightly different. You can't start saying, that's a lot of vibration, little vibration, it's very hard to, you can do it yourself and you feel, it's kind of hard to judge. It's not that good of a test for that, but it can help support a diagnosis. And those would be the reasons, right? If you had more on there, you're thinking more solidity, the sound goes there and vibrates more for the solidity, while an effusion would be like more liquid in there, it kind of dissipates it, it's not solid.
So less
Está ahí
vibe,
porque
like.
nena, pero en realidad no se hace.
So, you should know those kind
Entonces
of
el
general
CT y el
rules, well under
X-ray
what
lo que
conditions
determina
you
que no
might.
tiene.
I don't know.
Es más
So,
llamativo.
So percussion, we saw how to do that, right?
So the percussion